We had the real pleasure this year to make, I guess, 2 or 3 trips to Switzerland and had the wonderful opportunity of collaborating with the World Health Organization. Edward Kelly, Dr. Ed Kelly is the leader for their patient safety programs, and our 5 Rights program for imaging, we now have, for those that are not on the streaming video, we have a number of leaders that are on the stage. In our 5 Rights of Imaging program, we're collaborating with the CT and Radiation Safety Group. We're collaborating with Ed's group regarding their patient safety curriculum. And we had a wonderful opportunity of meeting leaders of the students around the world in multiple areas. And I'd like Ed to kick off our panel by describing the activities of the World Health Organization. And in our earlier panels, we have a very clear idea that safety, patient safety, is a common denominator across all nations. We have about the same number of people harmed in our OECD countries that we in America. This is a global pandemic of harm and waste, and one that's crippling every nation. And so the World Health Organization has identified education as a wonderful opportunity to have great impact. Would you please kick us off and give us maybe an overview of what the WHO is doing and how you're taking a standardized approach nation by nation?
Yeah, well, first, Chuck, thanks for even considering the global aspect of this, besides the fact that you does bring you to Switzerland for some nice cheese and wine. I mean, the tendency, I think, is to look at safety as a local problem. I mean, that's sort of what we teach people, to look at data and look at it locally and come up with solutions locally. But if you look, there's 7 million healthcare-associated infections in the U.S. and Europe. There's 234 million surgeries around the world, more than childbirth around the world. And there's somewhere on the order of 16 billion injections around the world. Now, the rates of healthcare-associated infection are 3 to 20 times higher in some nations, developing and transitional countries. You've got 70% of some of those 16 billion injections are seen as unnecessary. So it's a huge, huge problem. I think your description as a tsunami is apt. And the issue that you have frequently as an American, as the former director of the U.S. National Healthcare Reports, which I worked with Bill Meunier, David, other people, the tendency is to look at it from the data that we have here and not from a solution generation standpoint. But the OECD data that's out there, the U.S. does not compare well, and we're actually not getting better even. The problems that you have on reporting systems, on involving patients, other countries have been advancing on this, and I think it's something that we need to think about. For instance, I just came from a long flight, but a meeting of 36 countries in Salzburg where they issued a statement and asked me to come to this meeting and read it out to people, saying that they were calling on countries, policymakers, governments, NGOs, providers, patients, communities, to start to look at safety not just as what are worthy issues that Jim Bejan, Jim Nance, other people, Sully, have been highlighting here, which is improving the healthcare system, but actually as a global public health issue, as achieving that more health for the limited healthcare dollar that we get. And I think that's a common denominator that you get across every single one of the 192 member states that we have at WHO.
And I'd like to make a pitch to everyone in our U.S. audience and our global audience to go to the WHO and download the curriculum on patient safety. It is outstanding. I mean, if you were in our safety, we have a wonderful trustee from our safety net hospitals. What a great place to get free content that is evidence-based, makes a lot of sense, and is put together in a world-class way. We really commend you, Ed, and also for making the trip to come to see us. The area I'd like to address next is with Dr. Zeltner, Dr. Professor His Majesty Zeltner, who's a dear friend of ours, and we kid about him, was the former health minister of Switzerland, and they had many ways of introducing him. But he is such a treasure, because 19 years they're health minister. They deliver health care to 7 million people for 60% of the cost that we do. They take care of their poor. And I believe that their system, and as an entrepreneur, I can tell you, it's much less socialistic than our system is. And I think Dr. Zeltner would agree. But that's the issue that he commonly is asked to talk about. What I'd like to ask him to talk about is an area for which we have a great passion. The ARC report just addressed the fact that 2/3 of our U.S. staff, from 600,000 staff that were interviewed, 2/3 of them don't trust their leadership. 2/3 of them have distrust that if they announce that there may be an error on a patient, that they'll be held responsible. And a majority of them believe that if an error happens, that it will be in their own personnel report. And I know trust is a real passion for you. Describe your 5 elements of trust that I think are really insightful and how patient safety fits in those 5 elements.
Well, thank you very much, Chuck, and thank you that I can be here. I think this is really a very important moment in patient safety. Let's assume you or I go to a hospital right now. What I actually expect apart from being well treated is that I can trust the doctor, that I can trust the team, that I actually can trust the system I go into. And on the other side, and I love the way Bob Chapman has designed that, those who work in the system want to be trusted. And I feel that there are right now major challenges how to continue to build on that trust. And I have really figured out, and it's my personal vision on that or view on that, 5 elements which are in the air and where leadership at all levels is really asked for. Point 1 is really patient safety, and we have been talking about that extensively. How can you believe that people feel comfortable coming into an organization where, luckily now, there is much more transparency than in the past? But transparency generates this element of doubts, and we have to work with that. The second one, I think nobody talks too much about this, is the explosion of knowledge. And we know by now that it is very hard for a health professional to keep up with the knowledge. But it is also hard for patients to not doubt that the person in front of him or her is really knowing what is best practice. So that's the second thing. The third thing, and you just went through a very difficult debate here, is the limited resources and who gets what. And we do not want to get into a death panel discussion, but we are talking in the system of limited resources and that they need to be fairly distributed and that there must be mechanism. And if we are not able to organize that, the trust in the system will break down. The fourth element is, and we have to realize that there is so much speaking about you can't reform the health system. It's a system out of control. And you see that in many countries up of the level here in the US with the healthcare reform, but you see it on the lower level. And that is undermining the trust if the population has the feeling there is a system, but we have not control over it. That's no good sign. And the last thing, of course, is related to that, that special interests in the system are governing where the system goes. So I think there are major challenges when it comes to leadership. Leaders at the level of the hospital, leaders at the level of the county, or at the national and international level have to look at these different elements and have the benchmark. We want to keep the trust, period.
So, Steve, we've talked about earlier in earlier panels, and for our audience that has just come on board, Dr. Swinson has been a fabulous leader at the Mayo Clinic in quality. And when you think of the concept servant leader, you think of Steve Swinson. He is just personified. He's now moved from quality to leadership. Steve, in education, now that your job will be the leadership development of those at the Mayo Clinic, how will you help educate, coming back to the global concept of how will you educate leaders about their role for patient safety? As you develop the leaders, connect for us your former life as the head of quality and safety being really important and you being really good at it, to now leadership development. Help us, how do we connect those strands of DNA together?
Transparency has been a big theme here, and I think for leaders to transform an organization, that's the lever that they need to use the most, and it's sharing the programs with leadership, but it's also in this, one of the themes here this afternoon in this session is patient awareness. So breast cancer is a major killer on this planet, and we know that early detection makes a difference and saves lives. And yet, you could go to a practice that detects 40% of breast cancers, or one that detects 97% of them. But it's a totally opaque environment. A woman doesn't know if she's going to the 40% one or the 90% one, and she has a right to that. And if we had that information out there, we would change the game, because patients would have a choice, and leaders are the ones that have to make that choice. Maybe it's leaders of the country, maybe it's leaders of a hospital center, and then once those numbers are out, as leaders and patients, we can choose what needs to happen. But there's a moral imperative to open the books and let patients decide and let leaders manage to excellence.
Great. Now I'm going to the Cleveland Clinic. Dr. Henderson has done a terrific job of taking safety and quality and making it, to say it in a more popular way, making it cool. He basically picked really good doctors in different divisions of the Cleveland Clinic and made it a valuable and a respected thing to be the person in charge of quality for that division as part of your institute. And I think that was genius to do that. And so my question to you about education is, how do we educate our up-and-coming doctors, and even old guys like us, but the young doctors, to include patients that we have in this audience today on their teams, to kind of bring them in and say, we want you to be part of the learning of the doctor, so that we're not doing all of our learning over here and we prepare for our boards and the patients are in another part of the place, and then we're going to practice medicine, we're going to try to be really good in safety and quality. How do you, because you're doing such a great job of teaching your doctors, and I think the word that you came up with, trust, and what we put in the film, which was really important, trust. They trust you, Mike, and you are teaching them. How are you getting them to learn about patient safety, and how can we do it at the front line where we don't have Cleveland Clinic's resources? It's seen elsewhere where a hospital is a swap meet for business, or a farmer's market, as John so eloquently describes it.
Yeah, no, I don't think it happens easily, Chuck, is lesson number one. When I got into this, I'd been, as you said, I'm a surgeon, I've been doing a lot of high-tech stuff. But what I came to realize was that we needed to spread the new approaches to patient safety in a big way. And I realized in our environment, which is very procedural, operative-based, that a surgeon probably needed to step up and do that. And I suddenly realized that this would impact 100 times more patients than I'd been able to do in a pretty successful surgical career. So when I moved into this, I brought in all my buddies, my anesthesiologist, my radiologist, et cetera, et cetera. I said, I'm doing this. You made
it a cool club.
I said, if I'm doing this, you're coming with me. And they all said yes. So that was step number one, that the people who had clinically worked with a lot said yes. The first couple of years was pretty lonely, because our culture just wasn't at that level at that point. So having good people that I really trusted clinically on board was a huge step. Passing through that to where we're at now, and I think everywhere goes through this sort of evolution. As leadership came on board, convincing our first hospital, and then Cleveland Clinic has 10 hospitals, that enterprise leadership, this was important, was step one. And then it became much easier. When I first started, I said, in each of these areas, I like physician leads, because the docs are always the hardest people to get on board. And then it was really the team building beyond that, which is the phase we're really at now, that there are a lot of docs on board who commit have committed time to do this. So it's giving people time to think about and do the right things. Now, really, we're evolving to the point of how do we train at their resident, medical student levels within our system. And it's building on a fairly simple curriculum. And as you know, I keep coming back to the basics.
If you say it one more time, we're going to be calling you Dr. Basics.
But I'd been so lost in the high-tech end of it that the realization that infections is about the basics. Preventing errors is about the basics. The medication things, it's about the basics. And every time you keep coming back to that. So it's really, everywhere goes through a journey. And when I first had this, I thought, yeah, sure. But it's true. And it evolves. And I think how you start to train people depends where you're at on that journey. So it's getting the momentum going, building on that. And it's not going to be the same everywhere, but it evolves. And I think we're on a very accelerating part of that journey now, and that's really exciting. The first few years, I thought, oh, will we really ever
We really think, you know, we've had some conversations over the last couple of days here in Washington about the choosing wisely phenomenon of 9 societies saying, we're declaring that we're over-testing, and here are 5 tests where overuse is an issue, and really kind of broke from the pack to do it, which I think is a tectonic shift, and it's broken the surface tension of the stagnation of the physicians as leaders. I'd like to go to John Nance, and we've hit you pretty hard with every aviation question and NTSBs and that kind of thing, but John is a gifted guy who is a lawyer. He's a former airline captain. He's also an educator at boards, but he's also a master storyteller and a best-selling author. Can you tell us, John, you're now using novels, literally a novel approach, using novels as an educational vehicle about patient safety and about culture. What tips can you give us who are just starting out? I mean, in our films, the one we just finished is our second feature length. That's, most of it has been more educational, and toolboxes and that kind of thing. Share with us how we can use storytelling to get the message across, because this is a global panel. I'm going to come back to Ed. What's the common denominator across the globe about storytelling? And you don't have to talk about airplanes at all.
No matter whether we go back 50,000 years in human history and see people talking around a campfire and telling stories, or whether we're talking about the most sophisticated form of communication and doing exactly the same thing, this is how human beings transfer information in the most effective fashion. And it was no brilliance on my part. I've been writing nonfiction like this a couple of times before. Matter of fact, I didn't even figure out that I needed to do it the same way. But using the story of this fictional hospital to try to do something that, and I know you and I both had the same feeling with our time on the National Patient Safety Foundation, we wanted to get a model out there of what a hospital that did all these things right would look like, but it had not coalesced. So that was the idea. But to do a model, you take reality and then you structure with a few names that don't exist of people who in essence do, not using their individual stories but representative, and you show the interactions. You show the necessity, for instance, of training people in a hospital environment to be owners, not just involved, but to be owners. You show how difficult it is for intermediate level managers and directors to be nurturing of their people and to get rid of the ones who can't do that if they can't be retrained, because the nurturing of their people is really what it's all about. People get tired, they get upset, they get distracted. You have to show all these things on camera. Otherwise, there's always this barrier between the sterile effectiveness of a well-written paper that doesn't seem to involve human emotions and what really does, and that comes back to the nub of it. The reason that storytelling is effective, not just in a book form, but in any form of transparency, where we take someone, for instance, who has actually been harmed, and we bring them into the boardroom, and we bring them in, like Julie Towell, for instance, or like so many others who have been brave enough to step forward. These individuals are real living, breathing humans, and to confront the effects on them of a medical mistake, or to confront the effects on the rest of a group of surgeons, of a surgeon saying, I thought I was omnipotent and infallible because I was told I had to be, and yet here's what happened to me. These are invaluable. They can give you more in 10 minutes than we could achieve in 6 months of just kind of pointing the finger and saying, this is what we want to do.
Fantastic, and I think that I think we're all learning to be storytellers. I come as a specialist coming from a really technical background, like Dr. Parda here in the audience, radiation oncologist. We just love physics and 3D models of dose delivery and a lot of boring stuff. And it's a jump to start to say it's okay to tell a story. If you told me 10 years ago, even 5 years ago, that I would put on film going globally that I was praying with somebody that just forgave a pharmacist in that healing moment, I was choked up. I could hardly come up here after I saw what I've been looking at and we've been editing for months. I choke up right now as I think about it, seeing my own little boy on. Breaking down the barriers of emotion to get to the heart is really hard for us to do, especially the higher we climb in the medical field, the more scholarly and boring we have to be and the more focused that we have to be. And inviting patients into the boardroom is tough, and it could be harmful, and it makes us vulnerable. And as we come back to you, and then because I want to come to David about education, about educating folks about these technologies and the common denominators, but the storytelling piece, carry that through, because I know you'll have some great insights as a great storyteller, David. But I want to come back to you on the global, because this is a global panel. React to what you're hearing from a WHO. You are the neurosensory system to what's going on in the world, and if we don't listen to you, I think we're blowing it. So I want to come back to you and then to David.
Well, I think Jim's point about storytelling has two sides to it, because on the one hand, I think we're underutilizing stories in formal education settings in healthcare, generally speaking. But we started a program on patient stories. Sue Sheridan, who featured in the first film prominently, was one of the people who did this. And I frequently tell a story of that we gathered from a patient in Rwanda who described how the physicians, they treat us like farmers. They raise us as we are plants, but it's really for their own good. So it's from an agrarian society, but then a quote that I always pair with it is from a young guy who lost his mom at the best liver transplant unit in New York City, where they made the rounds on the day she died, and no one spoke word one to them as the entire surgical team walked in and out of the room as she was dying. And there's something universal. So that is in Uganda, Africa, and the best hospital in New York City. And there's something universal in how we're training our physicians, and the work that we have done on our curriculum is a start to try and address that. But it's not just an issue for trying to get that out there. It's an issue in the United States, too. Last year, 25% of office visits were attended by physicians who have a degree from another country. And I think we should care more globally about the issue of education, but it's an immediate issue here to make sure that globally people get the right education and patient safety.
So we're hearing universal, we're hearing leadership, we're hearing we've got the same problems, we're hearing the power of storytelling. David, as technically as HIT is, you're a master storyteller. Chris Jerry is standing back here, who went on camera and relived a terrible moment in order to save other lives. Can we use that in health IT? Can we use that in these cold, more technical areas, or are we blowing it because we're not using it?
Oh, we can definitely use it. We stand at the cusp of a wonderful moment, and it's wonderful because we're saying now that the delivery of healthcare services no longer is going to be a game of I've got a secret, okay? And that's so often that's what it was. And I think I'm going to make a distinction, and I don't know if there's really a distinction, but I think we have two jobs actually, to educate and to inform. With more information, we're going to be able to inform whole scores of individuals, providers. We're going to be able to inform patients about what is actually going on. But I think one important element we've got to put into all of this is we've got to educate people on how to use this information. Just giving you all of the facts won't necessarily empower you until you begin to understand how to use that information. We had a session before about the board. So many times the boards of directors of hospitals, they have the power to actually act, but they don't know how to use the information that they're given at the proper time in the proper way. So I think that we have two jobs working ahead, and I think stories are actually the best way to, one, inform, but also educate in how to use these tools and this information.
So we're out of time, but what we'll be talking about as we go forward is the evolution of education. How many people in the audience here in the press club would be interested in a special issue of the Journal of Patient Safety on education and this conversion from just knowledge transfer to competency, which we didn't talk about, but verifying the competency of our caregivers, and using storytelling, and using some breakthrough methods. A show of hands of how many would like to see a special issue. So as the editor-in-chief, I can tell you that TMIT will now be making the investment in funding that, because I believe that this is really important, and we'd like to have this panel be contributors, if they would, reviewers, that the World Health Organization is a treasure, and our former health ministers, we've been talking this week about all of these former health ministers that have been dealing with many of these issues, and so much we can learn from them. And we're really privileged to have Dr. Zeltner has become our assistant editor and our head of global programs for the Journal of Patient Safety. And we're so grateful to all of you for what you're doing in education, and the global education is so important. We find out that the world's getting smaller. It's flat and it's getting smaller. Thank you very much. So we'll take a 5-minute break for our next panel, and we want to thank you all very much.
Thank you.